and Jordana Ash from Colorado to share some of the innovative work happening in their states. We plan to have some time at the end for questions for the state speakers, and we'll wrap up with sharing a few resources. A few housekeeping notes before we get started. Technical information is available in the upper right pod labeled Technical Information, and underneath that pod you'll find today's PowerPoint available in a PDF document. As we are a large group today, we have put everyone on mute. If you have any questions or comments during the webinar, you are welcome to add them to the chat box. We will do our best to respond to your questions and comments in the chat box, and if we're unable to respond in the time that we have, we'll be sure to follow up after the webinar. We'll begin with defining infant early childhood mental health and exploring quality initiatives that support it. We'd like to start out by hearing from you. What is one word that comes to mind when you think of infant early childhood mental health? I am going to just pull over a word cloud, which is opening up a little chat box at the bottom of your screen here. And I invite you to take a moment to write the word that comes to mind into this chat box here. Wonderful. I see several of you have begun to write your words. This is looking beautiful. And as you write your words, as you'll see, a word cloud is being automatically generated with the larger words representing ideas that many people have and the smaller words representing ideas that one or a few people have. I'll give another couple moments for everyone to share their wonderful ideas. So I already see that relationships, attachment, trust were shared by several of you as represented by the larger words. I also see well-being, classrooms, connection, supervision, calm, bonding, really great words here. Great ideas representing infant early childhood mental health. I'll give another moment or so to see if any other words come to mind. Well, thank you for sharing your thoughts with us. We've created a beautiful work of art here representing all of our ideas, and it is clear that you're all bringing a wealth of experience and background on this topic. The caregiver-child relationship is at the core of infant early childhood mental health. A baby cannot exist alone and relies on the responsive care from supportive adults in his or her life. When we talk about infant early childhood mental health, we are talking about the baby and his or her parent, primary caregiver, or infant toddler care teacher. For infants and toddlers, it's all about relationships. In these early years, secure relationships form the foundation for well-being and future learning. Infant early childhood mental health, which is often used synonymously with social emotional health, is the developing capacity of a young child to form close, satisfying, and secure relationships with adults and peers, experience, manage, and express a full range of emotions, and actively explore the environment and learn. Importantly, all of this is considered within the context of a child's family, community, and culture. Infant early childhood mental health is not only about intervention and dealing with trauma, it is about thriving, about the best possible world for each baby with loving, responsive, and consistent parents and caregivers. The practice of infant early childhood mental health can be seen on a promotion, prevention, and intervention continuum. It includes promoting healthy social-emotional development, preventing disorders, and intervening where infant mental health disorders exist. It includes providing parents and caregivers with knowledge, support, skills, and experiences to best support the social-emotional well-being of infants and young children and to care for their own well-being. As we'll explore today, we can use an interdisciplinary systems-building approach to support infant early childhood mental health and strengthen the foundation being built for infants, toddlers, and their caregivers. Research shows just how important infant early childhood mental health really is. Infants and toddlers are affected adversely when stress threatens their family or caregiving environment. Some infants and toddlers also have adverse childhood experiences, including forms of abuse, neglect, and household challenges. These experiences can profoundly affect the way young children think, feel, and act, and are far more prevalent than we formerly thought. Toxic stress, trauma, and adverse childhood experiences can have a huge impact on a young child's developing brain and physiological system and long-term effects on behavior, emotional and physical health, and developmental outcomes. Very young children also can and do develop mental health disorders. It may be surprising to know that preschool expulsion rates are more than 3 times the expulsion rates of students in kindergarten through 12th grade. While the leading reasons for these expulsions is disciplinary or behavior concerns, the underlying causes may be overlooked, misunderstood, or inadequately explored, and may not have much to do with the child at all. As heartbreaking as it is to think about these issues, it's also uplifting that we have the capacity to support young children through early relationships and infant early childhood mental health services. Early relationships that are consistent and nurturing are critical for all young children. Stable and nurturing relationships can help a child through trauma or adverse childhood experiences, and positive and responsive interactions can help mitigate negative experience and develop a child's resilience. As we'll talk about today, there are family services within child care and across sectors that can support infant early childhood mental health. We know that there is a need for an interdisciplinary infant early childhood mental health approach to support infants, toddlers, and their caregivers through innovative programs that address parenting, education, child protection systems, mental health, and a host of related systems across every professional discipline. The Child Care and Development Block Grant of 2014 directs states, territories, and tribes to use a percentage of funds on activities that enhance the quality of child care programs. Among the list of allowable quality enhancement activities are behavioral management strategies and training that promotes positive social-emotional development and reduces challenging behaviors and expulsion practices. States, territories, and tribes can consider strengthening their workforce's ability to support infant early childhood mental health through a variety of mechanisms, including offering a progression of professional development on infant early childhood mental health topics that allow professionals to move from basic to advanced level training, establishing early childhood development credentials for entry-level teachers that focus on enhancing teacher skills and promoting children's social, emotional, and behavioral health, working with their local institutions of higher education to ensure that teacher preparation includes an infant early childhood mental health component, leveraging different funding sources to implement early childhood mental health consultation systems so that all early learning programs have access to knowledgeable early childhood mental health consultants, and developing or investing in endorsements that identify a set of knowledge, skills, and competencies in infant early childhood mental health. States, territories, and tribes can also consider building early childhood career pathways that incorporate progressively advanced capacity in infant early childhood mental health into their career ladder, adopting models to support early intervention and healthy interaction, such as positive behavior intervention and supports, the relationship-based care framework, and the teaching pyramid approach, integrating infant early childhood mental health within state and territory infant-toddler core knowledge and competency statements, including infant early childhood mental health content within child care regulatory professional learning requirements, and offering incentives for programs that address infant early childhood mental health, child care consultation within quality improvement initiatives. We have examples of the activities, strategies, and efforts states and territories are using to advance the mental health and wellness of infants, toddlers, and their families in child care. The examples we'll provide on the next few slides are specific to states and territories and are based on what was outlined in approved 2016 to 18 CCDF plans. The overview on the next few slides does not represent examples from tribes, as their CCDF plans were approved later than the state and territory plans. States and territories are using early learning guidelines and competencies to support infant early childhood mental health. As we mentioned earlier, infant early childhood mental health is synonymous with social emotional development. As of the 2016 CCDF state and territory plans, 54 states and territories have early learning guidelines for infants and toddlers, and 49 directly address social emotional development in their early learning guidelines. Many states and territories are making strides to develop core knowledge and competencies that include specific knowledge and skills required for the early childhood workforce to fully support infant early childhood mental health. And over 30 states and territories have developed or adopted infant early childhood mental health specialized knowledge and competencies. We've included resources in this presentation that provide more information about infant early childhood mental health competencies, as well as some state examples. States and territories have also developed infant early childhood mental health credentials, endorsements, and certificates for infant toddler professionals. At the time of the 2016 CCDF plans, 24 states were using the Michigan Association for Infant Early Childhood Mental Health endorsement. This endorsement system does have a cost, which may mean it's not the best fit for everyone. Several states are also using their own endorsement systems, and examples can be found in the resources that we'll highlight at the end of this presentation. Additionally, 18 states offer infant early childhood mental health related certificates and credentials via institutes of higher education. There are several types of infant early childhood mental health professional development supported by child care systems. This chart reflects the professional development models reported in the CCDF plans, and while it's not an exhaustive list of all the approaches states and territories are currently using, it shows how a variety of different professional development models are being used to support infant early childhood mental health. The pyramid model is a popular choice to support social emotional development of children within a group care setting. Early learning guidelines, program for infant toddler care resources, and state-developed approaches and trainings also are used to help providers and other early childhood professionals build knowledge and understanding of infant early childhood mental health, including social and emotional development unique to this age. Lastly, the large majority of states and territories reported using infant early childhood mental health consultation models in their 2016 CCDF plans.
Natasha, thank you for sharing information about infant early childhood mental health and data from the 2016 CCDF state plans. How should an infant early childhood mental health system look, and what are the essential elements needed? A system informed by the science of infant early childhood mental health would invest much earlier in the prevention of adverse childhood experiences by meeting basic health needs and offering high-quality early care and education programs. Such a system would actively promote infant early childhood mental health through practices such as routine social-emotional developmental screening for infants, depression screening for pregnant women and new parents, and home visiting for families of infants and young children, including infant early childhood mental health consultation support. And the infant early childhood mental health informed system would use all available resources and increase funding where necessary to train an infant early childhood mental health workforce and assure access to services. Infant and early childhood mental health remains a critical but often overlooked policy challenge. Compared to other issues affecting infant toddler well-being, infant early childhood mental health stands out in many states, territories, and tribes as lacking a comprehensive approach to prevention, let alone a system to ensure access to treatment after diagnosis. At its core, infant early childhood mental health suffers from a fundamental lack of understanding by policymakers best positioned to nurture change. The bottom line is that many state, territory, and tribal communities don't have the infant early childhood mental health services infants and young children need. They don't have the people to provide them, and they don't have a system that will pay for them. When federal and state, territory, and tribe decision makers address these areas for growth, our systems can address early foundational development of all infants and young children. And we create experiences for infants and toddlers that enable them to realize their full potential. Any professional who touches the lives of infants, toddlers, or their family in a relationship-based manner has the capacity to impact infant early childhood mental health. We all have a stake in this shared body of knowledge and work as a function of the variety of roles we play in serving young children and their families. As you can see, there are several sectors and systems that contribute to the mental health of infants and young children. This interdisciplinary approach strengthens the outreach of services and support, allowing for a more comprehensive approach to prevention and supporting infants and their families. Here are some strategies states, territories, and tribes may use to improve infant early childhood mental health. Promote the cross-cutting nature of infant early childhood mental health by creating a state, territory, or tribe strategic plan that infuses infant early childhood mental health into behavioral health, maternal child health, child welfare, home visiting, and Individuals with Disabilities Education Act Part C Early Intervention Initiatives. Also, consider growing the field of infant early childhood mental health by working with colleges and universities to offer coursework, training, and internships in infant early childhood mental health. Encourage greater attention to early identification and response by requiring a social-emotional component to screening, referral, and intervention requirements in home visiting, child welfare, and other early learning and development programs, as well as pediatric and prenatal health care. Increase access to infant early childhood mental health services and financing by advocating for language in state Medicaid and behavioral health plans to cover infant early childhood mental health screening, assessment, and treatment. This includes infant early childhood mental health consultation. Build capacity and competence in infant early childhood mental health practice by expanding professional development in infant early childhood mental health and consultation to support promotion, prevention, and referral for treatment. As mentioned, we can also grow the field of infant early childhood mental health by working with colleges and universities to offer coursework, training, and internships in infant early childhood mental health. CCDF funds can be used to support infant early childhood mental health, professional development, and consultation services in early childhood programs. Promote public awareness of the impact of early experiences on success in school and life by emphasizing the importance of social-emotional development for children to succeed in school, be healthy, and enjoy financial stability in adulthood. Develop an infant early childhood mental health association in your state, territory, or tribe. Now we would like to hear from you. Please take a moment to respond to the poll you'll be seeing coming up on the screen. In thinking through the infant early childhood mental health systems or sectors that touch the lives of infants and toddlers and their families, what infant early childhood mental health initiative is your state, territory, or tribe's current priority? What are you currently prioritizing in your state, territory, or tribe? Okay, great. I see some answers coming on. Looks like we have about 30% encouraging early identification, looking at about a quarter promoting public awareness, about the same amount building capacity and competence. It's hard to choose just one. I see the numbers changing. It is. They are all important. We have about half encouraging early identification. Not as many promoting the cross-cutting nature of the Infant, Early Childhood Mental Health Strategic Plan. Well, thank you so much for your responses and for sharing your state, territory, and tribe priorities in supporting infant, early childhood mental health. The questions provided on this slide are from the resource 0 to 3 from 2013, Nurturing Change, State Strategies for Improving Infant and Early Childhood Mental Health. For a full list of questions, please refer to this resource. It is listed at the end of our presentation. You can use these questions to assess the current landscape in your state to support infant, early childhood mental health. Some of these questions have been already answered in the data we provided earlier. Under Access, consider questions such as, what are the existing infant, early childhood mental health services and supports for expectant parents, infants, young children, and families in your state, territory, or tribe? Do the existing programs work in partnership with other programs that serve infants and toddlers? What gaps are there in services that currently exist? What are the eligibility barriers that limit access? What work has been done to address the gaps in service and barriers to access? And what more work needs to be done? For delivery, assess if your state, territory, or tribe has a plan for delivering infant, early childhood mental health services. Do they have a plan for embedding infant, early childhood mental health services in related children's programs? To what extent is there a formal training program for infant, early childhood mental health providers? Does your state, territory, or tribe provide infant, early childhood mental health training or consultation to individuals who work with children being served by other systems? And thinking about systems level issues, consider, do infant, early childhood mental health issues have traction in your state, territory, or tribe? Does your state, territory, or tribe have an infant mental health association? What kind of advocacy messages can you use that will make the case for infant, early childhood mental health services? And how is social emotional development reflected in state, territory, or tribe early learning guidelines and program guidelines? When considering financing, ask, how are the infant, early childhood mental health services and supports funded? Has your state, territory, or tribe examined current spending to determine where resources can be shifted to better support evidence-based infant, early childhood mental health services and supports across the promotion, prevention, and treatment continuum? What are the billing and payment barriers? And finally, when incorporating infant, early childhood mental health into practice and policy, consider, does your state, territory, or tribe have an approved list or definition of evidence-based approaches for infant, early childhood mental health? How are evidence-based practices reflected in your state, territory, or tribe public policy? For example, is parental depression screening a routine part of postpartum care? When considering the questions and strategies to build a system that supports infant and early childhood mental health, we may be wondering, where do we begin? Looking at it from an implementation science lens, here are some steps you can take. To inform policy decisions, the state, territory, or tribe planning and implementation team should begin with a systematic scan of existing data on the status of current investments across the state or system. The team can use the results of the scan to understand the status of current infant, early childhood childhood mental health investments and approaches to identify gaps. The comprehensive scan would target 4 key components: policy, practice, professional development, and technical assistance. In this next step, the state, territory, or tribe planning and implementation team can review the outcomes of the scan. They can access the degree, they can assess the degree to which current approaches are or are not meeting their expectations and work toward clarification of the goals and desired outcomes for the workforce. In step 3, conduct a fit and feasibility analysis to determine what combination of policies and allocation of resources is most likely to achieve the desired goals and outcomes. The purpose of a fit and feasibility analysis is to examine an array of options and assess the degree to which each option or package of options could be successfully implemented in the state, territory, or tribe. The components of a fit feasibility analysis include identification and validation of need and consideration of required changes. In the 4th step, the planning and implementation team selects an approach and develops the implementation plan based on considerations in steps 1 through 3. The team confirms the approach by delineating the targeted settings, sectors, related systems, and goals to align specific components on the overall PD system. A successful implementation plan will address the management of changes in the system, communications, regular review and monitoring, and data collection and reporting. In the final step, the planning and implementation team assigns tasks and timelines, monitors results, and makes system adjustments as needed. Implementation occurs through assigned roles and responsibilities for specific action steps, and a timeline for completion is considered in steps 1 through 4. To the extent possible, the implementation plan should build on the information gathered to date and use the results garnered through step 4 on the considerations. Results from the data collection and monitoring of implementation inform revisions or modifications to activities. Appropriate selection of staff, ongoing TA, and analysis of data to inform decisions can support this process of continuous improvement and help the state, territory, or tribe planning and implementation teams reflect on lessons learned as the approach is implemented and the PD system matures. Next, we will explore 2 state system approaches.
Julie, thank you so much for sharing that information about infant early childhood mental health systems building. We are incredibly lucky to have 2 state speakers, state presenters, joining us to share the innovative infant early childhood mental health efforts in their states. And we'll have some time after the speakers' presentations to respond to your questions and comments in the chat box. I'd like to first welcome Ashley McCormick from Michigan, who is an infant mental health specialist and endorsement coordinator with the Michigan Association for Infant Mental Health. Welcome, Ashley.
Thank you. Today I'm going to be talking about the Michigan Association for Infant Mental Health, or I-ECMH, endorsement system. The endorsement for culturally sensitive, relationship-focused practice promoting infant and early childhood mental health is intended to recognize experiences that lead to competency in the infant, young child, family field. The I-ECMH endorsement system was developed to recognize and document the development of infant, early childhood, and family professionals. It does not replace licensure or certification, but instead is a credential meant as evidence of specialized knowledge, skill, and practice in the infant and early childhood mental health field. Endorsement is cross-sector and multidisciplinary, including professionals from child and/or human development, education, pediatrics, psychiatry, psychology, social work, and others. Endorsement is a verifiable process that is based on several competency areas and specific requirements. Endorsement examines the ways of knowing, doing, and being. The ways of knowing are examined through an endorsement applicant's level of education and participation in in-service training. The way of doing is examined through an endorsement applicant's work experience, delivering high-quality, culturally sensitive, relationship-focused services to infants, young children, and their families. Finally, the way of being is examined through experience, receiving guidance from reflective mentors, supervisors, and consultants. The I-ECMH endorsement is based on the I-ECMH Competency Guidelines. The development of the Competency Guidelines goes back to the mid-1980s. During that time, federal legislation was passed requiring family-centered service coordination for infants and toddlers with delays and/or disabilities. In Michigan, the Department of Education was in the lead for implementing these services and identified competency domains for early intervention professionals. I-ECMH committee members built on these competency domains and identified areas of core competency for infant mental health professionals. The vision and creation of what we now know as the Competency Guidelines was carried out by a diverse array of professionals from multiple disciplines who in some way touched the life of an infant or young child and their family. The Competency Guidelines serve a few core purposes. First, they create a shared framework across all sectors and disciplines of the infant, young child, and family field across the full spectrum of service delivery, including promotion, prevention and early intervention, treatment and intervention, and policy, research, and practice. Second, they can promote systems growth and change. And third, they can be used to build a comprehensive infant and early childhood workforce to support, intervene with, and sustain mental health. The I-ECMH endorsement is comprised of 4 categories. These 4 categories span across various types of education, work, and reflective supervision experiences. To date, I-ECMH has endorsed 665 infant family professionals in Michigan. The categories of the infant mental health endorsement are infant family associate, infant family specialist, infant mental health specialist, and infant mental health mentor. Infant mental health mentor has 3 designations: clinical, policy, and research faculty. We are excited to announce that an early childhood mental health endorsement credential is coming soon. Currently, Michigan, Connecticut, Alabama, and Pennsylvania are in the process of rolling out the early childhood mental health endorsement with just a few applicants in each state. The early childhood mental health endorsement will be appropriate for professionals working with or having expertise in the area of 3 to 6-year-olds. As noted on the previous slide, the 4 categories of infant mental health endorsement span across various types of education, work, and reflective supervision experiences. On this slide, we're going to look at work experience. Infant family associates make up 12% of those endorsed in Michigan. This category may be the most appropriate fit for those who work in promotion, for example, early care and education. Infant family specialists make up 57% of those who have earned endorsement in Michigan, and this category may be an appropriate fit for those who work in prevention or early intervention, like a Healthy Families America home visitor. Infant mental health specialists make up 19% of endorsees in Michigan, and this category typically fits those who perform infant mental health treatment and intervention, like infant or child-parent psychotherapy. Finally, infant mental health mentor applicants make up 12% of those who have earned endorsement in Michigan and is an appropriate fit for applicants with leadership or indirect infant mental health work experience. More specifically, infant mental health mentor clinical is an appropriate fit for providers of reflective supervision or consultation. Infant mental health mentor policy is most appropriate for advocates and system administrators, and infant mental health mentor research faculty fits those who research and teach about the infant mental health field. you can see that the infant mental health endorsement truly cuts across all sectors of professionals who work with 0 to 3-year-olds and soon 0 to 6-year-olds. Systems and institutions in Michigan have been impacted by the adoption of the Competency Guidelines and Endorsement, including changes in higher education, improvements in organizational capacity for reflective supervision consultation, changes to professional development standards, and funding for service delivery. We're going to take a quick look at some major changes that have taken place in Michigan over the last 17 years. A few minutes ago, I explained that My-AIM started the process of thinking about creating the competency guidelines dating back to the mid-1980s. In 2000, My-AIM received funding to hire an executive director, complete the competency guidelines, and create a systematic plan for workforce development, which we now know as Endorsement, which was finalized in 2002. In 2007, the Child Care Expulsion Program included Endorsement as an infant family specialist as a requirement within their hiring guidelines. And in 2009, Medicaid required all providers of infant mental health home visiting programs in the state to earn Endorsement as an infant mental health specialist preferred or infant family specialist required. Infant mental health home visiting is a unique service of the Michigan Department of Health and Human Services, provided statewide by 46 community mental health provider agencies. For decades, My-AIM has been lucky to have champions at the Department of Health and Human Services who believed in the verifiable process of endorsement and were integral in requiring that all infant mental health home visiting providers become endorsed for Medicaid reimbursement. Many of the system changes on this slide, with Part C, the Maternal Infant Health Program, and the Child Care Licensing of Michigan, took years to go into effect. My-AIM leadership was and is committed to being the voice that asks, "What about the baby?" at every single table and meeting. This means being present at interdisciplinary task force meetings and serving as liaisons to various organizational boards and talking about how commitment to workforce development for 0 to 3 professionals ultimately equates to better outcomes for infants, toddlers, and their families. We do not yet have quantitative data on endorsement to share with other systems, but we do have some qualitative data that can be used in these meetings. For example, when asked what professionals say about the benefits of endorsement to families, we have heard, "I think it maximizes my capacity to be fully present with them. I am a more well-rounded clinician due to requirements for reflective supervision and continuing education. And I'm a better advocate in court." Finally, just this year, the University of Michigan received $1 million in funding to evaluate infant mental health home visiting, which I referenced a couple slides ago, to become an evidence-based practice. Michigan Infant Mental Health Home Visiting is a voluntary model delivered by clinically trained master's level professionals who provide weekly home visits to Medicaid-eligible pregnant women and families with infants and young children. What sets infant mental health home visiting apart from other 0 to 3 home visiting models is that clinicians are trained in and provide infant parent psychotherapy, which offers parents and caregivers the opportunity to express and understand their feelings from past or present trauma, loss, abuse, neglect, or depression that threaten to interrupt the development of secure, stable, and enduring parent-child relationships. Clinicians who provide the service must be endorsed as an infant mental health specialist. Finally, I did reference the early childhood mental health endorsement earlier, and for me, that's all for my presentation, and I'll be happy to answer questions at the end. Thanks so much.
Ashley, thank you for sharing the innovative and exciting work that is happening in Michigan. I see several participants have included some questions in the chat box, and I invite participants to continue to write questions and comments in the chat box for both Ashley and our next speaker, Jordana, and we will address them after Jordana's share. And I would now like to welcome Jordana Ash, who is the Early Childhood Mental Health Director with the Colorado Office of Early Childhood.
Good afternoon, everyone, and thank you, Ashley, for sharing in detail about the infant mental health endorsement, which is certainly an important aspect of building a highly qualified workforce and essential for a comprehensive early childhood mental health framework. We heard earlier today about important areas of systems. Let me just back up a second. There we go. Sorry about that. I got a little ahead of myself in my eagerness to share what Colorado is doing with you. But first off, we're going to ground ourselves in Colorado's approach to the systems building work, which is so foundational to everything that we can achieve in infant and early childhood mental health. So as I started to say, we heard earlier today about important areas of systems considerations. Each state, region, and territory will have its own unique approach based on local conditions, political will, history, and likely a little luck. I will begin telling Colorado's story by addressing these questions. It will be brief, but it's in an effort to give you a sense of things to think about and how you may go about this journey in your own community. First off, while there's certainly recognition that infant and early childhood mental health activities, interactions, and interventions occur in many early childhood serving systems, in Colorado there was an awareness that if we wanted to institutionalize some of these practices and align them across different disciplines, organizations, and agencies, we would need a position of leadership within state government. This position in and of itself is a reflection of a visionary state-level systems approach to early childhood mental health needs of both families and providers. That's the position that I hold. And my responsibilities include serving as an internal and external expert for infant and early childhood mental health issues. Sometimes that's working with our corrections department to consider attachment issues for inmates and their families. And sometimes it's testifying in front of our Early Childhood School Readiness Legislative Commission on adversity and resilience for Colorado's population, and frankly, everything in between. Being responsive to all sorts of requests cements the importance of my position as integral to the vast array of early childhood efforts that are happening here. So just how can communities address financing, barriers, and access to an early childhood mental health system? As Julie noted, we found that investing early on in the development of an early childhood mental health strategic plan with broad stakeholder input at all stages of its creation has been key to guiding allocation of time and resources for both my work in the Office of Early Childhood and for work across Colorado. There are numerous partners that we have who are also focusing on this issue, and together we're making substantial progress to the overall goals that are laid out in the strategic plan. Developing this plan was the primary focus of my work for the first year in the director position. One thing that we found useful was to have a graphic representation of the other state-level initiatives working on the priorities that are articulated in the Early Childhood Mental Health Strategic Plan. This illustrates the intersection of effort and partnerships that's being leveraged for success. And that document is one of the documents that you can upload from this webinar. It gives stakeholders a quick view of the breadth and scope of early childhood mental health work in Colorado. And just to highlight the 3 priorities that Colorado identified in our strategic plan are having a fully financed system for the continuum of services from prevention through early identification and intervention and treatment. The second priority is integration across all early childhood systems, including increased access to services in community and health-related venues. And thirdly, we have a workforce priority, which includes emphasis in our state on achieving the infant mental health endorsement, which Ashley described. As a strategy that's front and center in our state early childhood mental health strategic plan, we have seen individual programs and practices successfully build costs related to endorsement into their own work plans and funding requests. So now to turn our attention for a moment to the important reach of policy and practice, we have a powerful example of how Colorado achieved this. We've been able to incorporate early childhood mental health practices into our child care system through rulemaking. A couple of years ago, we used the opportunity of the state rule revision process to include advances in key areas such as how providers are supported to improve practices around social emotional development, methods and approaches to reducing suspensions and expulsions, and improving partnerships with families when children present with challenging behaviors. In 2016, in Colorado, rules were adopted that require providers to cultivate positive child, staff, family relationships, to create and maintain a socially, emotionally respectful care environment, to implement teaching strategies to support positive behavior and social emotional competence in young children, a required team-based approach to reducing challenging behaviors and preventing suspensions and expulsions, and demonstrated access to early childhood mental health consultation. So that brings us to what the system looks like in Colorado, and I have a couple of items of information there on the slide. But I wanted to take a moment here to describe Colorado's consultation system and to address why we built the part of the regulation that speaks to access to mental health consultation into child care rules. Our notion was that since mental health consultation in Colorado and likewise across the country is a capacity building approach, we wanted child care providers to improve their abilities to proactively think about how they would connect with these consultants, that they would get to know their local person, and that they would establish partnerships with consultants in advance of any issues. Building this into rule raised the visibility of the early childhood consultation resource across Colorado and increased the responsibility of the provider to take steps to connect. Colorado's state-funded mental health consultation system can be said to have started in 1997 with a pilot program at 2 community mental health centers. That successful program expanded in 2006 with state general funds for 1 full-time equivalent position at each of the 17 mental health centers across Colorado. So we were ready to make the case for expansion of that program when the national spotlight turns its attention to quality in child care, disproportionality of exclusion practices, and a general heightened awareness of brain science. We wrapped all of that into our request for spending authority to use our child care development funds for an additional $1.7 million a year to double our infant and early childhood mental health consultation system. And so now we have funding for 34 positions, which are filled by about 42 professionals. I just want us to reflect for a moment back to that original word cloud that all of us together made and put together, and some of the key labels that we thought of and concepts that we thought of when we first began just to sort of on impulse think about infant and early childhood mental health were relationships, trust, and understanding. And certainly those 3 concepts have a key role in what I'm going to describe next. And what you see there on the slide is the picture of a set of escalators going up to the top of the mountain, which is very fitting for Colorado. Another key component of Colorado's success in building our consultation system is our collaboration with a group of well-informed philanthropic partners. About 3 to 4 years ago, a number of local funders organized themselves into a learning network to take a deep dive into early childhood mental health issues and to become active collaborators in many areas, including maternal mental health, integrated care, and mental health consultation. A subset of these funders have provided financial support for an additional 24 positions across Colorado. Our state commitment has been to include these privately funded consultants into all of our trainings, resources, and use of our database, which together has led to increased statewide access and support. So many of you may be thinking about your own state or region's philanthropic landscape. and wondering what to do if these relationships do not yet exist or have not been so fruitful to date. While it may be slightly complicated, I would suggest you asking yourselves, what are the starting points? What's of interest to local funders, and what problems or challenges can you bring to the table that they might think together with you about, or even as a beginning, to just learn more about? What do you know that you can share? So yes, we're excited about the challenges ahead. We feel optimistic that 2018 will be a successful year for infant and early childhood mental health topics and concerns in Colorado and nationally. Together with our partners from a wide range of organizations, we will continue to use the Early Childhood Mental Health Strategic Plan to shape and instruct our efforts. Specifically, we're going to continue to work with our Medicaid colleagues to try to figure out how to access funds to pay for some prevention activities for child-focused cases in consultation. We are actively finalizing important infrastructure elements for our consultation system so that all Colorado consultants, regardless of who pays for their position, are working from the same set of principles and standards. To that end, we hope to improve our culturally responsive approaches, to uphold high-quality benchmarks while still embracing new professionals, and, as always, to use data to understand and improve services so that all children, families, and providers thrive. Thank you. That's the end of my
Jordana. Thank you, Jordana. And Ashley, I appreciate you both sharing about your state's process, and there are a few questions that came to mind for me, and I was watching the chat box to see if any others came up. One of the first questions that came up was around, and this is for Ashley, Michigan's early childhood mental health endorsement, the difference between the 0 to 3 and the 3 to 6. Could you expand on that, Ashley?
Yes, so I neglected to mention that the competency guidelines that I referred to, when that was created to cover birth to 5, so up until a child's 6th birthday. So we have the competencies in place for 0 to 5, and the infant mental health endorsement covered those first 3 years. It's focused on work experience with the 0 to 3-year-olds. So because we have the competency guidelines in place and that framework was already there, the early childhood mental health endorsement really just closes that gap. It covers the work experience that one has with 3 up until 6-year-olds, up until a child's 6th birthday. So the competencies are the same. We're expecting that people have the same skills and level of knowledge, but the work experience for those two is just different, because we do know that the infant and early childhood mental health field is one that has expanded a lot in the last few years to include those children up until 6.
Great. So in terms of moving forward with that, it says that it's coming out soon. Do you have, could you mention about when that will be happening for that endorsement?
Yeah, so I also was glancing at the question. So I will provide a little bit more information for everyone. The infant mental health endorsement is currently being used and has been licensed in 29 other states, U.S. states. So we have licensed them to infant mental health associations to use the infant mental health endorsement, which, like Natasha said earlier, does have a financial cost to it. So each of those 29 states can currently endorse those infant and family professionals who work with 0 to 3. The early childhood mental health endorsement will be optional for those other states to add. So Michigan, Connecticut, Alabama, and Pennsylvania have already licensed it and will be rolling it out. Our guess is the end of 2018, but it's not going to be required for all of the states, all 29, to go ahead with the early childhood mental health endorsement. So I noticed that Rhonda Reardon Nelson in the comments box did share a link that has all of the states listed who have purchased the infant mental health endorsement license. So if you want to go to that link, you can find out more about infant mental health endorsement in those states, and then I'm sure you can follow a trail back to who you could contact at that association and let them know or ask them if they will be using the early childhood mental health endorsement there.
Great. Thank you so much for that information, Ashley. I appreciate it. In hearing Jordana's share about Colorado, a question for me came in around how did you leverage bringing the early childhood mental health practices into the rule revision process? What did that look like?
Certainly. You know, we knew that the state rules would need to be revised as they are in likely each state and territory on a fairly regular basis. And so we had an opportunity to gather a number of interested stakeholders and experts to think about what would be the most important practices to put forward in state rule, knowing that there is an important, transparent, iterative process to get those rules approved where provider groups and parents and other folks who are involved in quality improvement practices all can respond to state rules that are proposed. So we did go through a process where we wanted to elevate the visibility of social emotional development and always work in partnership with our early care and education providers to make sure that any rule changes that we suggested took into account their needs and the support that they needed to grow in this area, to make sure that there were seamless ways to access supports, not only for challenging behaviors, but for new and additional learning in these areas. So we decided to land in a couple of key sections of the plan around guidance and discipline where we talked about the practices that needed to be put in place in order to think deeply about children's behaviors and what it might mean for parents and providers and what that behavior is telling us. We also were able, in those child care rules, to increase the number of hours of annual training that providers have on social emotional development. So our responsibility on the other end of that was to make sure that there were free and accessible learning opportunities for providers so that they could continue on their professional development growth. So 3 of the 15 clock hours that our early care and education providers need to have each year have to be dedicated to social emotional development. So those are just a couple highlights. Julie, I didn't know if you had another specific question.
Nope, that's great. I just wanted a little bit more background on that. Thank you so much, Jordana.
Certainly.
And unfortunately, we only have a minute or so left, so we do need to wrap up our webinar today. Thank you to everyone who provided questions and comments in the chat box. I did want to note again that this PowerPoint is available for download in the middle pod in your screen on the right-hand side. I also added a link to Colorado's Infant Early Childhood Mental Health Strategic Plan that you can find in the chat box. And there are a number of resources we've included at the end here on infant early childhood mental health. So please feel free to review these resources as they provide just a wealth of information for you. So this wraps up our webinar this afternoon. Please take a moment to complete our feedback form. We've provided the link to the form in the chat box, and we'll also email the link to you in the next few days. And thank you, Ashley and Jordana, for being with us to share your stories. We'd also like to thank Holly and Rana for providing technical support behind the scenes. And many thanks to all of you for your participation today and also for the wonderful work you're doing in your state, territory, or tribe to improve the quality and supply of infant-toddler care. And we look forward to being with you on the next Hot Topic webinar, which will be on the 6 essential practices for quality infant-toddler care. And that will be on Wednesday, December 20th from 1:30 to 2:30 p.m. Eastern Standard Time. Thank you again for your participation today and have a wonderful afternoon.